Welcome everyone to today's webinar, Is Endoscopic Spine Surgery the Future for Pain Management? I'm Mackenzie Bean with Becker Spine Review. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them in the Q&A box you see on your screen, and we're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it's now my true pleasure to start the webinar by introducing our presenter. Dr. Tony Mork is an endoscopic spine surgery specialist and founder of the Endoscopic Spine Academy. He has a keen interest in sharing his 20-plus year body of knowledge and expertise in endoscopic spine surgery. Dr. Moore created Endoscopic Spine Academy as a way to effectively teach the surgical procedure and further the adoption of minimally invasive spine surgery. He is board certified by the American Board of Orthopedic Surgery and is a fellow with the American Academy of Orthopedic Surgeons. Dr. Moore, thank you so much for joining us today, and I'll now turn the floor over to you to begin the presentation.
Thank you very much. Today, I'm just going to try to talk about the Endoscopic Spine Academy and really just in three parts. So there's going to be kind of three major headings, and then there'll be a few points under each heading. And it really won't take too long, I think about 15 or so minutes, so it should be quick so we can get to your questions. But the way I'd like to start is, when it comes to spine pain, have you ever thought that pain management treatment was not quite enough and that traditional spine surgery was just too much? This was a question I asked myself in 1998 when I made the 100% move to an endoscopic spine surgery practice, and since then I've done over 9,000 surgeries and have never performed a fusion. You, as pain management specialists, have one significant diagnostic advantage over the typical spine surgeon and one technical disadvantage. The advantage you have is that you do all your own diagnostic work, which means that you naturally discriminate between the different pain generators. As an example, the pain from a bad facet is usually in a different location than the pain from an annular tear, and you have the diagnostic capability to differentiate. An accurate diagnosis is essential to the correct treatment regimen for any given problem. The disadvantage you have is that no matter how accurately you can diagnose a problem, you don't have many of the surgical options to permanently relieve the pain. This is where endoscopic spine surgery comes in. It is the skill set that can address the huge gap of treatment options between pain management and traditional spine surgery. The one thing that makes my practice different from the typical spine surgery practice is that I do all my own diagnostic work. This is a significant advantage and allows me to identify pain generators that others may not have found. As a solo practitioner with a cash practice, you have to have an edge, and my edge is being able to diagnose the source of pain and offer an endoscopic cure. Patients that are in pain and frustrated want two things: a diagnosis and a cure. With experience, it became clear to me that certain pain generators are located inside the spinal canal and other pain generators are located outside the spinal canal. By far, the majority of pain generators are located outside the spinal canal. The good news is that most of these pain generators are easily accessed with a 7-millimeter endoscope. I published a paper in 2010 about curing facet pain endoscopically back in 2010 that I've continued to update with current day equipment and techniques. As I get closer to the end of my surgical career, I believe it's important to have this knowledge stay alive and be available to practices around the world. I think that it's important to save the spine and avoid fusions whenever possible. Endoscopic spine surgery allows you to divide and conquer pain problems in the spine and move towards curing pain rather than just managing it. When you cure spine pain, you can significantly reduce and eliminate the use of opioids in your practice. Okay, let's talk about the three main takeaways from this webinar today. There are three, and the pain management doctors can and should consider endoscopic spine surgery now for three main reasons. One, you do not have to operate in the spinal canal to cure the majority of spine pain. Two, the decision to cure pain rather than manage it will transform your practice for you and your patients. Three, endoscopic spine surgery can boost your bottom line significantly. All right, let's talk about the first one. You do not have to operate in the spinal canal to relieve back and neck pain. The vast majority of spine pain generators causing back and neck pain are outside the spinal canal and are primarily the facet joints and sometimes the discs. You are already at an advantage to treat back and neck pain because you are already doing your own diagnostic work. Back and neck pain can be very elusive, and I don't think it's sufficient to simply look at an MRI scan and intellectually decide that you know where the pain is coming from. Over the years, I've noticed the importance of doing my own diagnostic work and talking to the patients after their blocks. I began to see multiple contributors to spine pain, particularly from the facet joints and toxic annular tears of the discs. There is no group of doctors that knows more about facet pain than the pain management doctors. It's also been my impression that the typical spine surgeon doesn't have much interest in facet syndrome or treating it. Yet, facet syndrome of the cervical, thoracic, and lumbar spine is a significant cause of back and neck pain that is typically treated with RFA or radiofrequency, which is always a temporary fix. What if you could offer a permanent pain relief with an endoscopic procedure instead of temporary? With instruction and proper training, there is not much difference between a 2 millimeter radiofrequency needle and a 7 millimeter endoscope. You have to be very familiar with the anatomy of the spine to be an interventional pain management doctor and place a diagnostic or therapeutic needle where it's supposed to go. Placement of a 2 millimeter RF needle is a surgical procedure performed with radiographic guidance, and frankly, there isn't much difference between placing an RF needle or a 6 millimeter obturator that acts as a guide for a 7 millimeter tubular retractor. The big difference is what you can see with the endoscope. You can observe the facet joint, the capsule, osteophytes, loose bodies, and spurs that can act as pain generators. You will see a whole new world of pain generators when you start looking inside of a facet joint with an endoscope. You do not need to be inside the spinal canal to cure this pain. All you need is proper training in the use of the endoscope to cure facet pain. Let's talk about the second part. You will transform your practice when you decide to cure pain rather than manage it with opioids. Who do you want to shape and change the evolution of your medical practice? The outside entities and agencies, or you? For example, at this point in time, your practice is being transformed by the opioid crisis. The government and big pharma are working to eliminate the use of opioids as much as possible in the treatment of pain. No matter how you look at it, a pain practice based on the use of opioids is no longer a viable option. You and your patients can bemoan this trend or move in a new direction to learn and acquire a new skill set that allows you to cure pain rather than manage it with opioids. Why not add some technology and a new skill set to redefine your practice in the 21st century? Make your focus to cure pain rather than manage it. Your patients will love the new direction of your practice, and for the first time, you can really distinguish your practice from other pain practices with this new focus. With a little education, the other group that will appreciate your efforts will be the local spine surgeons, because you'll be able to deal with the smaller pain generators that they don't have much interest in training. There isn't much difference between a 2 millimeter RF needle and a 7 millimeter endoscope, but that 5 millimeters can represent a world of difference to your patients. The whole outlook about pain will change when you actually see the problems that are causing the pain. You can see the capsules and synovium that are being pinched, as well as loose bodies and osteophytes that are causing these problems. When you have endoscopic tools, you can actually fix the problem after you make the diagnosis. You and your practice can rise above just managing pain. You can cure it. This new perspective and understanding of pain will occur naturally as you use the endoscope to look at the various causes of pain and then be actually able to treat the problem. I have heard several pain management doctors describe how unhappy they were when they viewed their pain as a prescription practice. The endoscopic technology available can really give your practice a new edge and direction, a direction that can help avoid burnout and extend your working career. Let's talk about the third aspect. Endoscopic spine surgery can significantly boost your bottom line. The best part about being a pain specialist is that you already have an abundance of these patients in your practice. You don't have to create any elaborate marketing campaigns to attract these patients. If you perform one facet surgery a week, it could increase your bottom line by $50,000 a year or more. When you begin to think of how many facet problems there are, you could be pretty busy doing these facet surgeries. Of course, the course includes the CPT codes for each procedure. All these endoscopic procedures are performed in an outpatient setting. This means that if you're an owner of an ASC, you can receive even more financial benefit by introducing endoscopic spine surgery into your practice. When you control the facility costs, you can make your services even more beneficial by offering packages. In a personal injury practice, you can decide what the facility charges for a given procedure. If you've ever wanted a cash or fee-for-service practice, this might be a manageable way to start. I've had a cash practice for over a decade, and it's a good way to go in certain instances. It can work well for various groups of people, particularly self-insureds, or those who have a very high deductible, or those who belong to a medical group that doesn't offer such services, or visitors from another country. Packages can be created to include evaluation, diagnostics, and surgery, and the benefits of a cash practice are numerous, especially with the reduced personnel necessary to serve your patients. The Endoscopic Spine Academy offers online education, hands-on training, and exclusive mentoring. And we'd like to share with you one student story with you before we move on to the Q&A after the video.
My name is Jason Capra. I live here in Pensacola, Florida. And right now I'm Chief of Endoscopic Spine Surgery at Neuromicrospine practice. And I've been doing endoscopic spine surgery for about 8 years now. And I've done thousands of procedures, but the more we do, the more skills we have, the more different parts of the spine we want to work on, and we want to start challenging ourselves to broaden our experience. So I knew there was an area of the spine, the cervical spine specifically, that I had never done this specific procedure. I knew that I had the skills to do it, but I did not have the confidence at all. And so when you're trying to choose people to learn from, there are very few that have a large amount of knowledge, experience, and a good reputation, and have been trained by the founders in the field. And Dr. Mork is one of those people. So you can go to workshops, you can learn from a lot of different people, but I don't want to just learn from anyone. I want to learn from the best because I want to be the best. And if I'm putting my hands on someone, then they deserve the best. And that's why I chose to learn from Dr. Mork, and that's why Dr. Mork and I remain close personal friends and associates, because I'm not going to put my patients at risk by not having adequate knowledge and learning from someone who's not an expert. My favorite part about the course is that it's very structured, and this is how all of the products that he puts out are. He's a very good teacher, and when you watch the course, you know at each step, at each module, what you're going to be learning and what you have learned. And it's arranged in a way where you can then go ahead and review those modules. I also like it because it's extremely comprehensive. You're not just learning anatomy. You're not just learning how to do the procedure. You're not just learning the equipment. You're not just learning billing. You're not just learning, you're learning all of those things together in one package. And I just haven't, honestly, I haven't seen that anywhere else. And I especially think that the way that he actually shows not just the procedure. We have other people, you can watch YouTube videos, you can see someone putting a scope and they'll film the procedure from inside the camera. But he actually takes a step back, shows you the operating room, shows you the positioning of the patient, shows you how to position the arms, the back, the leg, shows you what cushion he uses. It's so helpful to see that outside view because that's going to be you in the operating room. You're going to be responsible for all those things. And once you get the scope in, then the fun starts. But he teaches you everything leading up to that part and then how to actually do the procedure as well. So I really appreciate that part of it. And so when I showed up the next day at the surgery center, I knew everything to have it laid out, and I did it exactly according to the video. And it's not that it wasn't anxiety-provoking, but I knew that I was prepared. And the case went great. And I actually called Dr. Mork that day, and I made sure I thanked him personally, saying, if it wasn't for you doing this, this patient would not have had this care, because I would not have been confident enough to do this just on my own. I would definitely recommend this course to anyone that is trying to either get into endoscopic spine surgery and doesn't know where to start, or already is in endoscopic spine surgery but wants to branch out and do more complex things. The reason why is that it's not just about going to a cadaver course and learning the procedure. You have to know all of these other unmentioned variables that you don't even know where to look for the answers. And you're looking in some places for anatomy, you're looking at some places for billing, you're looking in other places for equipment. It's laid out all in one place. And the peace of mind that you can get from saying, I know where to go, I'm going to study the material. The night before the surgery, I'm going to go back over the video, I'm going to study it again, and when I come into the surgery, I'm going to be confident and I'm going to know exactly what to do. I honestly do not know anywhere for endoscopic spine surgery that kind of product exists. And this is not only one of the only products, but without a doubt, even if there are other products, they don't match the quality of this one.
Wonderful. Well, Dr. Mark, thank you so much for such a great presentation. I believe we are ready to start our Q&A section now. So if any audience members have questions that they'd like to ask Dr. Mork, please submit them into the Q&A box you see on your dashboard, and we will try to get through as many questions as we can. So it looks like we already have some good questions rolling in, a few of which are asking where these procedures can be performed. So Dr. Mork, the first question is, can these procedures be performed in an ASC, or do they require surgical privileges at a hospital?
I think that they're best performed in an ASC. Of course, they can be done in a hospital, but really no benefits there. An ASC is the place that I have done this for years.
Perfect. Thanks for clarifying that. And then we have a related question where an audience member is asking, can this be done in an office or only an ASC or hospital?
You know, it probably varies from state to state. It probably could be done in an office, but you've got to have all the proper anesthesia equipment and the monitoring equipment as well. So I think that at least I've looked at it kind of superficially in the past, but when they told me exactly what equipment was needed for anesthesia, I decided it was just best to do it in a real ASC.
That makes a lot of sense. Thank you for clarifying that. The next question is, what type of credentialing is required to be able to perform these procedures?
It probably varies from facility to facility, and I think that you just have to apply. You probably have to have some training that you could cite. Most of the time, there's nobody at the ASC who does any of these procedures and could really effectively credential you. So I think that just showing up with some teaching credentials might be just enough. But it varies from place to place.
Got it. Thank you again, Dr. Mork. And are these procedures covered by insurance?
All the codes that I use are standard codes. so the insurance does cover them.
Wonderful. And how many patients would you say are interested in these types of procedures, or do you see it as a hard sell to patients?
So we kind of, again, I have I have a non-insurance or cash kind of practice, and I would say we kind of looked at it one time. We get between 20 and 25 calls for people who would demand insurance per one person who is willing to, go for it on a cash basis. So there's not a hard sell at all to it. As a matter of fact, if I took insurance, I really wouldn't be able to even go home at nighttime.
Well, it sounds like the demand is definitely there. We have another audience member who's asking, you referenced an increase of $50,000 per year with one facet procedure annually. Is that just the physician's fee, or does that include the facility fee as well?
No, that's just the physician's fee, and that's on the low side. I try to give the reimbursement on the low side. So that would just be doing, one facet procedure, one a week, and that's just for the surgery charge. Has nothing to do with the facility.
Perfect. Thank you for clarifying that. We have another audience member here who is asking, are there a variety of endoscopes that are available, or do you have a specific brand that you would recommend?
There are, there's actually a few companies that actually have, this kind of equipment available for use. So that's all I can say is that there's more than one out there.
Absolutely. And, keeping on the technology perspective, what technologies do you see coming that will really enhance this procedure, if any?
So what's come? Say again?
Sure. This audience member is asking, what technologies do you see coming that will enhance this procedure?
I don't think that you need too much more technology to do this. You just need the endoscopic equipment, and with a couple of them, I supplement it with the use of a laser for just kind of technical purposes. But as far as any kind of robotic, if someone is asking really about robotics, completely unnecessary with this type of procedure. There's plenty. You can do it easily with the kind of the recommended equipment and training.
Wonderful. Thanks for clarifying that. And what would you say is the most difficult part of adding these types of surgeries to a pain management practice?
So I think it's just the physicians have kind of a point of view. They need the training. The ASC needs a little education as well about what to expect from the financial benefits. So sometimes I've heard doctors say that, I presented it to the ASC and I'm getting some pushback. But that's simply because the ASC doesn't really know about what codes they will be using for the purposes of billing. And actually, in January, I believe, of the upcoming year, I will be doing a webinar for the ASCs so that they can understand the financial benefits of adopting this kind of technology for pain management practices.
Perfect. Thank you again for touching on that. We have another question here from an audience member, and I'm going to apologize in advance if I mispronounce anything, but the question is, I have a lot of patients with foraminal stenosis with radiolopathy. Would an isolated foraminotomy be part of the advanced course?
So I've divided the courses into beginning courses and then more advanced courses. So a foraminotomy, so I've got a total right now online of 5 courses. I'm almost finished with the course. You're asking about the foraminotomy course, but I consider that to be a second level type of course, and will be soon available. But it requires a little bit more practice and a little bit more experience to do that surgery safely. So I called the course Transforaminal 2. Transforaminal 1 is part of the basic courses. Transforaminal 2 is a second set of courses.
Perfect. I think that's helpful for our audience to know. A related question is an audience member here asking, how does this differ from endoscopic rhizotomy?
So it depends on which joint you're talking about. So an endoscopic rhizotomy might be okay for the lumbar spine, but I've integrated a little bit of extra kind of removal of some of the tissues and maybe a little bit of some of the bone for the lumbar. As far as the cervical and the thoracic, it's very common to find some bony little problems, such as an osteophyte or some overgrowth of the kind of the edges of the bone. And so you have to be dealing a little bit with some bone removal rather than just removing the nerve, so to speak. You want to actually address the real problem that's causing it. And at least from the paper that I published back in 2010, it seems to be, that had the minimum follow-up of 3 years, so we consider it to be a permanent fix rather than just a rhizotomy where you're going to divide the nerves and they just kind of come on back.
Wonderful. Thank you for outlining those differences. Another interesting question here from an audience member who is asking, would there be a value to including intraoperative neuromonitoring during the endoscopic procedures?
So I actually have never used neuromonitoring except at the request. Sometimes I've been operating on maybe orthopedic doctors and their families. And so if there's an orthopedic spine surgeon and I'm operating, I did one here maybe a year or so ago on his dad's neck, and he insisted on neuromonitoring, which I have never used and I don't recommend. It's just, it doesn't add much because the only time you get an abnormal signal is after the fact. It's maybe one thing if you're doing a deformity case and you're applying pressure slowly and you can see something happening gradually. But in this, if you unfortunately ever hit a nerve, the damage has already been done. So what's the point of a neuromonitoring? The other thing is that in that particular case where I was doing the neck surgery, we got some very abnormal readings, which were very distracting during the case because the spine surgeon thought that the nerve was being injured. But there was, I'm looking at the spinal cord and nerves. Again, I'm in the spinal canal, which is not what I'm recommending for this discussion. But I found neuromonitoring to not only be not helpful, but it was actually a distraction for endoscopic spine surgery. I'm not talking about the use for other types of, say, deformity type of surgery or something like that.
Absolutely, that makes sense. So the next question focuses on recovery, and this audience member asks, how are your patients tolerating the recovery time, and how long is the typical time of recovery compared to needle-based procedures?
Yeah, so recovery, I would say that probably 80% of their pain is pretty much gone within the first 10 to 12 days post-op. My biggest problem with these people is that the pain and everything goes away so quickly that they get too active too quick. So in just simple facet surgery, since you're just dividing soft tissues, you're not really decompressing, nerves or the spinal cord, for example. You're not working in the spinal canal. So if they get overactive afterward, they can end up with say they just get overactive and they just will hurt for a little extra time, but the recovery is not really interfered with. So it's Band-Aid surgery. There's not much in the way of follow-up. It's one stitch under the skin, steri strips, and the dressing comes off after a couple days, and they can pretty much do what they want. There's no physical therapy. I don't use that on a routine basis.
Wonderful. Thank you again, Dr. Mork. The next question we have is additional med-mal coverage required for this? So
that's part of the service that I've tried to make this whole thing pretty seamless. And if you do have to be cleared by your malpractice carrier if there's ever any, say, questions. I have found carriers that will, cover pain people who want to do this type of procedure. It's not really that difficult. I've only used a couple of different people, but they've just said, if you have people that are trained and they want to do this type of work, it's usually not a problem getting coverage.
Wonderful. It looks like we have one more question here. This audience member writes, Chronic pain can lead to persistence of symptoms even when anatomic causes have been corrected, presumably due to changes in the CNS. Are there any subsets of chronic pain patients more likely to benefit from this?
Well, I think that probably the most chronic pain group that is really not well understood but responds pretty well to a lot of this are the people with toxic annular tears, particularly of the lumbar disc. These people can have symptoms for years and years and are oftentimes just kind of put into the chronic low back pain that don't respond to physical therapy. They don't respond to injections because the problem is inside the disc. Yet when you go in, investigate the problem, and then endoscopically treat these like lumbar discs, it's remarkable how much change you can get in a relatively short period of time.
Great. We've actually had two more questions come in. The first is a follow-up question about insurance coverage. This person writes, even if the codes are covered, will they cover them under anesthesiology or pain management instead of a primary surgical specialty?
Well, I don't know because I've always submitted the codes under a surgical specialty, but I don't know why you want to submit it under anything but a surgical specialty.
Perfect. Well, let's move on to the next question then, which is, how long are your typical procedures in terms of duration?
It depends on how many of these, it depends really on a couple of things. One, how much experience do you have? It determines, how long it's going to take you to do a certain facet type of case. And the more experience you get, the quicker you can do these so that you can tackle more at one sitting. So typical, like let's say take cervical facets as an example. If you've got, you can do up to maybe 3 or 4 of them maybe in the beginning. It's going to take probably in the beginning, maybe 30 or 40 minutes per level. So that's about maybe between 2 and 4 is what you want to tackle, just to avoid fatigue. And but as you get more experience, you can tackle 6. And so I would say when you're more experienced, you can do a single facet in maybe 15 or 20 minutes. So it has to do with, what the level that you think you can handle personally and the amount of time. These people are, kind of face down, and oftentimes they get some pressure on their face. So really, you don't want the operative time to be going much more than about 2 hours.
Perfect.
So it kind of depends. It depends on your own experience. You have to keep the patient's well-being in mind, as well as your own fatigue.
Absolutely. And what procedure would you recommend starting with for someone first learning endoscopic techniques?
So I put the courses in order of difficulty. So the first one I suggested is the lumbar facet debridement. It's straightforward. There's only one way to get in any trouble, but it would be hard to do. And it's easy. It's very forgiving. It's very successful. And the patients are usually very happy after getting the procedure. So I would start the lumbar facet. Number 2, I would do the cervicals. I know it seems a little bit maybe dangerous to some people, but putting an RF needle in is not that much different position-wise than an endoscope. And then the third would be the thoracic. Just from a technical point of view, it's just a little bit more difficult. And then the last I would do, even though it's a little maybe easier, the transfemoral discectomy is, I put that on as last because you're inside the disc and you're passing through the foraminal canal. I think that that's kind of the order I put them in for people.
Perfect. Thank you for outlining that. The next question is, what procedure are you actually doing for annular tears, and do you complete a discogram before proceeding?
Yes. So I do provocative discography followed by a CT scan to diagnose conclusively that they have an annular tear and to identify which one is the one causing pain. Then I do an endoscopic washout. So it turns out, at least in my experience, is that the fragments, it's the nucleus, because I stain these with an acidophilic dye. So you're looking at dead tissue, and probably the nucleus is degenerating, and the fragments, which are pretty small, not enough to cause a disc herniation, are actually migrating peripherally through the annulus, and they get interposed in the annular fibers, and also they can be causing a chemical reaction. So washing out the fragments turns out to give, probably 80% of the people at least a 50% relief of their pain, which I think is pretty good since it's such a benign kind of treatment.
Absolutely. It looks like we have another question here relating to endoscopic spine instrumentation, which I think you might have touched on a little bit, but I want to make sure we are covering all our bases. So this person is asking, is there specific endoscopic instrumentation that you prefer to use and that in your experience are better to use compared to others, or any insights you're able to share on that realm?
So I've actually used all the different companies, and they're all fairly similar, and so they all some may have a little bit, maybe one thing that people like or don't like. So it's just almost like driving a car. It's just an individual thing. Overall, the equipment is fairly similar.
Definitely. So it sounds like up to personal preference a bit.
Correct.
Perfect. Well, the next question here is from an audience member who is asking, I know you are a progressive spine surgeon, but many seem to push back aggressively about even procedures outside the canal. Do you have any advice on how to proceed with local medical politics issues?
I think that, again, each is a little bit different. So sometimes it's just a matter of approaching the ASC. They are much easier to deal with than hospitals, for sure. And I think that if you provide the ASC with enough evidence and kind of the idea of how you're kind of progressing forward and how they can generate some additional business, it's just that sometimes doctors just show up with a request to buy equipment, but the ASC doesn't have any real reason to buy it, or they can't really imagine why they should or what the volume of patients are. So I think a little bit of education of the kind of the governing bodies of this can be, helpful. And as I said, I'll be doing a webinar, I think, in January of next year that is really designed for the ASCs on why they should be why they should be supportive of this type of surgical procedure.
Fantastic. Well, we have touched on so many great questions, so thank you to our audience for that. And Dr. Moore, thank you so much for all of your great insights and answers. Before we end the presentation, I just wanted to turn the floor back over to you one more time to see if there are any final thoughts or takeaways you'd like to share.
Well, I just really encourage people to give this technology, really some thought. And the more I've used it, and I've used it for now over 20 years, the more I use it, the more I kind of learn about pain and different things that I can do to eliminate it. It's just been kind of one of the most refreshing things I've introduced in the practice of pain control for myself, just because it's very interesting and the patients just love it. They're getting a relief of their pain on an outpatient procedure with a 3/8 inch incision. It's just, I just remain enthusiastic about it as I have been, and just more so every year.
Wonderful. Well, Dr. Moore, thank you again so much for such a great presentation. And thank you to Endoscopic Spine Academy for sponsoring today's webinar. I hope everyone enjoys the rest of their day, and we look forward to having you join us for future webinars.
Thank you very much.